So the first presentation today is from Dr. Lowell Ling. Lowell is an intensive care physician from the Chinese University of Hong Kong and is one of several visiting researchers and collaborators that are coming to join us for today's forum. We've been very fortunate to collaborate with Lowell on a number of projects, and I've been able to witness myself some of the wonderful insights that he's been able to bring to the studies which we've been planning. And I'm very interested in his views on what the importance of antibiotic dosing is for optimising health outcomes. If I could invite Lowell to join us now.
Thanks for inviting me from Hong Kong. Thank you, Jason and Jeff. So for the next 10 minutes, I'm just going to talk to you about importance of antibiotic dosing, really from a clinician's point of view, and really to give you a flavor of what's to come this afternoon. So I'm sponsored by these groups who sponsor my research and some of the work that I do in Hong Kong. Gordon Ramsay's on spot here. Who here does a bit of cooking? Okay, so anyone makes roast chicken? Can you season it properly?
Full of carcinogens.
Full of carcinogens. That's for another talk. Is it easy to season a chicken? Sometimes. Yeah, if you season it too much, it becomes too salty and it's not edible. If it's too bland, you don't season enough and it's not edible either. I have a really good recipe for 6% hypertonic saline chicken. If you want it, I can share it with you, Jeff, after the talk. So as you can see, Gordon Ramsay makes it easy, but it's actually really hard. And so does it matter? Well, it does, because if you look at Ling 3, which has just come out, depending on which side of the river you sit, maybe. But if you look at sort of the clinical cure and also the mortality for me, the signal is very clear. That there's it's not for debate anymore, because we know continuous infusion achieves a much better dose and much better PK, PD thresholds. And of course, are we doing it though? The classic DALI-2 trial, which is almost more than 10 years ago now, showed that there was a 500-fold difference between patients who were treated, clinicians thinking, okay, this is the right dose for you, and you just sample them. We found that there were 500-fold difference across these beta-lactams. So clearly, we're not seasoning our chickens in the right way, or at least we have different tastes. So why does it matter? Well, the site of infection really is one of the key factors why we might need to think about different dosing. The patient factors would also be an important thing to consider. The pathogens itself are also important. And also, of course, the antibiotic. So often we think about the site of infection, or at least we used to think that if we just sample the blood, we would know what it's like acting at the site of infection. We now know that that is not true. So we have a lot of studies now showing that the epithelial lung fluid, if we sample it, we find that a lot of the hydrophilic antibiotics are not actually there at all, or not even at the right dose and not achieving the MIC that we want. And of course, the kidneys. Well, the kidneys can either act both ways. You can be a renally excreted antibiotic, in which case then you don't need to give such a large dose because it excretes out through the kidneys. But if you have a urinary tract infection, which is only sensitive to drugs which are not excreted in the kidneys, then that becomes a problem. And particularly for patients who are shocked, does the kidney even receive the adequate blood supply is another issue. And classically, of course, the blood-brain barrier is a huge problem. We often have patients who have brain abscesses, and we can actually access and get into the brain because of the blood-brain barrier. And unless you have meningitis to go along with it, it's very hard to penetrate. And so that's why sometimes we actually have to infuse drugs. If the patient actually happens to have an extra ventricular drain, then that may actually help you, but otherwise it's actually quite difficult, and you might have to dose super therapeutically for the rest of the body just to get the blood into, just to get the drug into the brain. And soft tissue infection. And who actually gets soft tissue infections? Well, it's the patients who have diabetes, right? These patients have peripheral vascular disease. So, well, the first reason why they have these soft tissue infection is because they don't get blood supply to that area. Well, if you're not going to get blood there, how is the antibiotic even going to get there, right? So again, very difficult. And deep-seated infections. So if you have a huge liver abscess, how is the drug, again, going to penetrate into the liver? Again, very difficult. So site of infection is something we have to consider when we think about antibiotic dosing. And depending on the site and the bug that you have there, you have to give a different dose. The patient, what are some patient factors? Patients with septic shock, the bread and butter of ICU. Patients with impaired tissue perfusion, again, if the blood is not getting there, how is your drug going to get there? So studies have shown that patients, again, with soft tissue infection who have septic shock, a lot of them are not achieving, let alone therapeutic drug concentrations, but actually a lot of them are not even having any drug in the soft tissue when you measure it. And a lot of times is what we do to the patient. So all the fluid shift, fluid resuscitation changes the volume dynamics and also the volume distribution, and it also causes huge problems to the drug, particularly for hydrophilic drugs, which can then spread across a lot of different spaces in the body. Altered kidney function, notice I use word altered here. It can either go against you, or for you, depending how you see it. Reduce renal clearance. So for drugs which are cleared renally, then your dosage could actually reduce as the patient develops renal failure. But of course, if the patient has renal failure, we then put them on dialysis and we do bad things to them again, trying to save their lives. We then change their volume distribution significantly. And also in young, fit men who have augmented renal clearance, these patients, again, need a huge dose because they're actually clearing more of the drug than you think they are. And liver impairment, a similar story. So most patients either have renal or kidney impairment. That's why they're in the ICU. And for this group of patients, it's sepsis. And so these patients have reduced hepatic clearance. And again, those drugs which are cleared hepatically also need dosage adjustment. But the biggest challenge is actually the protein binding. So a lot of the drugs, the antibiotics that we give, require the free concentration to act. And once you alter the protein binding, either because we're giving albumin or because the patient has low albumin because of sepsis, then the problem becomes, again, of volume distribution. And again, you need to adjust the dose. Let's see. Okay, so pathogen came up. Okay, so pathogen, of course, we also have to think about the MIC levels of these drugs and whether your pathogen is a really strong boxer. And so again, if you are giving drugs which are not actually hitting the bug correctly, then again, what chance do we have to clear the patient's infection? And lastly, the antibiotic that you're giving also has to be considered. So if you have beta-lactams, classically, you're going to go for a time above MIC. And then for fluoroquinolones, you're going to go for AUC under the curve. Whereas with the aminoglycosides, you're going to go for Cmax, concentration max, and plasma. So again, antibiotic dose also depends on the antibiotic that you've chosen for your patient. So this is my last slide, but I'm going to go backwards since they didn't show up, and I saw my thank you slide already. So why does it actually matter? Well, I was going to show you a slide on sort of how many patients of sepsis there are in the whole world. Take a guess. How many? 50 million. Someone has read the latest papers. Yeah. So 50 million. Okay, so 50 million is a very good guess. This is not an auction house. How many deaths?
No matter what the next side will.
Sure. Oh my gosh, how did you know? So 11. Okay, I'm going to go somewhat harder. How many children? Too many. Too many is the answer. Too many. Yeah. But how about the proportion of deaths? How many deaths do you think is due to sepsis in the world? And we've also verified this in Hong Kong. How many adult deaths are partly responsible for how many adult deaths are partly responsible for due to sepsis? 1 in 4. 1 in 4. So we just without getting into the nitty-gritty of this, this was a really large GBD study. It has its own problems, but we independently verified this using very objective data, and we came to this same conclusion that 1 in 4 adult deaths in Hong Kong was partially treated for sepsis. So it's a huge problem. And so there was going to be another slide, which was going to be the arsenal of weapons that we have against sepsis. So how many weapons do you have against sepsis? I have 5. So as intensive as I have 5. So if the patient can't breathe, I put them on a ventilator. If they can't pee, I put them on a dialysis machine. If they're shocked, I give them fluid and vasopressor. But these 3 are really supportive measures. And really, we're just buying time for the patients to get rid of the infection. And I'm not a surgeon, so source control is not mine. And then so I'm just left with antimicrobials. So really, that's why it's so important to get the dosage right. And so with that, I'll tell you that it's important and particularly grateful for this opportunity to share with you to raise awareness of antibiotic dosing and also how to choose the antibiotic and also to give the right dose to the patient, but also to promote research in this area. And as we've seen over the last 10 years that we still don't do it right. We don't know how to roast a chicken properly. We don't know how to season one. And so lastly, it's really about translating what we know from the awareness, the research, and putting it into practice to improve patients' outcomes. So with that, thank you very much for your time.
So you'll see that we have a very ambitious program today, whereby we have 10-minute presentations at the start, and in the second session we decrease down to 7-minute presentations, and there's a lot that we're trying to get through. So thanks very much everyone for following us through here.